And go to the presentation, Dr. Bidipta Behera and Dr. Gautam Mandal of Fortis Hospital. So you have to restrict your presentation to 4 minutes each. Okay? You have to 8 minutes total presentation time, so you restrict your presentation to 4 minutes each. Dr. Bidipta Behera will come first, and then Dr. Gautam Mandal from Fortis.
I am going to present our experience with ileal new bladder in muscle invasive bladder cancer by Dr. Bidipta Behera and Gautam Mandal. First case, a 55-year male, known case of hypertension, occasional smoker with normal bowel and bladder habits without any neurological illnesses, presented to the local hospital with painless hematuria plus passage of clots with multiple episodes for last 5 months. On investigation, CT scan revealed an avidly enhancing large endoluminal polypoidal mass, left posterolateral wall of size 69 into 62 into 44 mm, obstructing the left uretary orifice with left-sided hydroureteronephrosis, mass avouting the left superior surface of the prostatic parenchyma. Tuberosity was done outside on 12th of June 2023. A histopathology report suggestive of high-grade muscle invasive, poorly differentiated PCC. Post-tuberosity, when patient presented to us, we have done some CT images. So these are the images which can show the hydronephrosis of the left side and the tumor on the left lateral wall and in the trigone area. Patient presented to Dr. Srinivas Narayan with above reports with further management. Per abdominal examination was normal. Digital rectal examination revealed grade 1 benign field prostate with normal overlying mucosa with normal arenal tone. Discussed operative procedure and offered choices for both ileal conduit and ileal neobladder reconstruction. Advised to quit smoking. Patient opted for neobladder reconstruction. Cystoscopy showed regrowth at the trigone area. Patient planned for TUR biopsy of the bladder neck and prostatic urethra. Histopathology suggestive of chronic cystitis changes, and pre-operative preparation were made and planned for definitive surgery. Next case, a 62-year male, a known case of hypertension without any surgical history, smoker for last 25 years with normal bowel and bladder habits, presented to a local physician for painless hematuria with passage of clots for 2 days. On investigation, CT scan, CT KUB suggestive of large enhancing intraluminal soft tissue lesion involving the dome and the anterior wall of the urinary bladder of size 6 into 4.5 cm. Cystoscopy showed and tuberosity showed solid type lesion located on the dome of the anterior wall extending up to 2 cm proximal to the bladder neck. Histopathology revealed invasive high-grade urothelial carcinoma with deep muscle involvement. Presented to Dr. Ayush Chaudhary with above reports and for further management. Per abdominal examination, bladder was not palpable. Digital rectal examination, grade 2 enlargement of benign field prostate, anal tone was normal. Then the patient was planned for neoadjuvant chemotherapy followed by radical cystectomy. Patient was referred to medical oncologist per preoperative neoadjuvant chemotherapy, received 5 cycles of cisplatin plus gemcitabine based neoadjuvant chemotherapy, offered to choose between ileal conduit and neobladder. Preoperative counseling was done. Patient opted for ileal neobladder. Next case is a 43-year male without any comorbidity or past surgical history, no history of smoking or normal bowel and bladder habits with and his family was complete. Presented to local hospital with dysuria and gross hematuria without clots. On ultrasonography found to have 2.5 into 2 cm polypoidal intraluminal hyperechoic structure protruding from the right lateral wall of urinary bladder. Cystoscopy plus tuberosity, resection of solitary polypoidal growth from right lateral wall plus deep muscle biopsy. Histopathology suggestive of high-grade urothelial carcinoma with deep muscle involvement. Presented to Dr. Ayush Chaudhary for further management. On per abdominal examination, bladder was not palpable. Digital rectal examination, grade 1 enlarged prostate with normal anal tone. This advice for.
Please don't mind, as we are running short of time, may I ask a question?
Yes, sir.
So many cases you are presenting, what is the purpose? What is
Sir,
the
this
special?
is.
Is there anything special things in each and every case?
No, sir. Actually, this enumerate the pre-operative preparation, how we prepared these cases and how we present it. There is no such.
What are 4, 3, 4, 5, 6
Yes, sir. Yes,
cases?
sir.
There is not no, sir. One, remember, please proceed. I realize this. Proceed, please proceed quickly.
So then pre-operative preparations, all the patients were counseled for CISC. Issues like future impotency and erectile dysfunction were explained to the patients. Smokers were strictly advised to quit smoking. Neurological illnesses excluded. Urethral stricture excluded. Multidisciplinary team created. Comorbidity were properly addressed. Nutritional assessment was done. Pre-operative blood investigations like hemoglobin, serum creatinine, blood grouping, LFT, albumin, ILP, and bilirubin. All the patients had pre-operative negative urine culture. Blood equation were made beforehand. Consent were taken. Parts prepared. Stoma marking was done. Restriction of solid from previous day afternoon. Mechanical bowel preparation and IV antibiotics were started. Patients were allowed for carbohydrate-rich drink till 2 hours prior to the induction of anesthesia. Next, the operative management will be discussed by Dr. Gautam.
Tea is ready, Dr. Behera. You are Dr. Behera, no?
Yes, sir.
Why you ask the patient to stop smoking?
So smoking is a causal association with the bladder cancer. That's why we are stopped smoking.
Or smoking, bladder cancer has happened, okay. But now his life is not, long life is not ensured. Why you are making deprived of this comfort?
আমি এক কোশ্চেন করছিলাম তুমি সমস্ত
Yeah,
কেসে
easy answer, but sir.
এনএসসি তুমি তোমার পাঁচটা করে দাও তোমাদের অনেক বেশিরভাগ কেসে তো পাঁচটা করে দিও এমনি তো তুমি তিনটে দাও দুটো দাও
How do you assess comorbidity of the patient? How do you assess comorbidity of the patient? Theoretical question. No. Patient has come to you, you are preparing for operation. You have to see whether patient is fit regarding the comorbidity, whether fit or not.
Yes, sir. So, go for cardiac workup like.
Any of the students, how the comorbidity of the patients are assessed? Which? Tell that. What are the different parameters and how? What are the?
চার্লসনটা বলো চার্লসন
একটা তো বলতে পারলি অনেকগুলো আছে একটা তো বলে সেটা মুখস্থ বলতে হবে পরীক্ষা জিজ্ঞেস করবে তো তখন বলে হবে না হাইপারটেনশন ডায়াবেটিস এভরিবডি নো ক্লাস 12 স্টুডেন্ট অলসো টেল দ্যাম
Well, তুমি বলো।
Good afternoon, sir. Post-radical cystectomy, we planned for new bladder preparation with the ILM, but there are some things that we should keep in mind for next part, that we send the ureteric end for biopsy, and we may take 6 suspending sutures to the membranous urethra. For continence in post-op period, we should ensure few things, like the ureter too broad in the midline, adequate intrapelvic length of urethra is very important. That should be ideally 1 to 2 centimeter. There should be good hemostasis, and neurovascular bundle, if possible, should preserve. But in our case, we couldn't, and the pelvic floor should be intact. This is the patient position, and incision marked, and ureteric end are sent for HPE. Coming to the main part, there is a modified studer, how neobladder is formed in our cases. We have taken ideal segment, that is 15 centimeter from the IC junction. Total length of the bowel should be 64 centimeter. Among this, the distal 44 centimeter, we make it a pouch, and with 15 centimeter, that makes a chimney, and last 5 centimeter that was removed to gain the length, so that the neobladder can be brought down to the pelvis. These are the steps. Firstly, we detubularize the bowel and form the posterior layer. Once the posterior layer formed, we can see both the ends, and next comes double folding. when the bladder is formed in a spherical shape. And at that time, when we plan to close the anterior layer, we should do three things. First, we place the UCAT or infant feeding tube in this patient through the abdominal wall, then place through chimney, and then to the ureter. Secondly, we place a SPC close to the mesenteric border, and then we close the anterior wall. So after forming the new bladder, now it's turn to take it down to the urethra. The urethral end are stitched with 6 sutures, preferably with Vicryl 30. And the chimney, which is formed, now in our cases, we preferred Wallace to anastomose the ureter with the chimney. Immediate post-op period, the patient, all of them was uneventful. Most important 2 things are there. First is bladder cycling, and secondly, tablet nodosis we started once we started for per oral feeding. Coming to the follow-up patient, in our cases, we removed the SPC and ureteric catheter on 3 weeks. After 1 week, we removed the parietal catheter, and for monthly follow-up, we advise for hemoglobin, creatinine, and biochemical parameters were assessed. At 1 month, we look for USG, KUB, and uroflowmetry, and at 3 months, we plan for CECT whole abdomen and pelvis. 2 most things for the follow-up part, that is CISC. So CISC in our patient, we started twice a day, preferably before going to bed and before after getting up in the morning. And our all patients were continent. 1 patient we found initially night incontinent, but gradually over 6 weeks, he developed continence. 1 patient, single external iliac lymph node was positive, and he received adjuvant chemotherapy with gemcitabine cisplatin. Thank you.
Your flow rate is 30 ml per second. How is it possible?
Sir, in our patient we train. In our patient we train. As these are bowel segments, so obviously there is no muscle movement. But patient is advised and trained in 3 things. Number 1, they are asked to pressure abdominal pressure to increase the body. Secondly, in some particular patient, we also ask for particular position like squat to increase the flow rate.
Maybe also pelvic relaxation
Pelvis
exercise.
also balsam and pelvic relaxation. This also helps, sir.
Probably not all the patients.
Not only
Maybe because this throat is very high, I think. So if there is any question from the house,
Actually, the flow rate becomes high.
yes.
The flow rate becomes high because there is no urethral resistance.
Okay.
Rather, the prostatic resistance is removed. So they have like a gush depending upon the abdominal tone. And probably because these were young patients, that is why they are having such a high flow rate.
One thing.
Yes, sir.
What is how Studer chimney is effective for anti-reflux mechanism?
Sir, it is not anti-refluxant.
It is not anti-refluxive?
No, sir.
Then why the Studer chimney is created?
So chimney is created for the anastomosis of the both ureter.
In ureter, you can join the ureter in the pouch itself. Rather, you are keeping a blind tube.
So the ureter also maybe the length may be short and not long enough to bring it to the bladder itself. So chimney helps to.
Chimney itself causes continence. Chimney itself is continence mechanism.
Also, this peristalsis
Yes, sir.
may not be total, the blood, but
But it should be clear that chimney itself is a continence mechanism. Chimney continence से काज छोड़ जाता
And
है.
that बोलते yes, it is chimney is created for the purpose of what is called anti-reflux. Because the brunt of this reflux pressure is taken up by the chimney and ureter is spared from the.
also the peristalsis.
But one question, it is nothing theoretical. I have no exact answer also I don't know. Because Wallace you have done where? At the top of the tube.
Yes, sir.
Top of the tube.
Yes, sir.
So that means there is a chance, it is very, I am not sure, but I am telling you, there is a chance the directly pressure may be mitigated towards the kidney through the Wallace. Or where usually you do with the beakers, From the side you have put the, am I right, sir?
Sir, Mike.
So pressure is taken up by the cap of the closed ideal.
Okay.
I am not sure, it is just an idea I am telling you, how far it is right or wrong, my comment I don't know.
Little bit taken out.
But I never heard anyone is doing OLS in student chimney for that time.
Are you doing project section for the ureter?
No, sir.
So what is the disadvantage of polish?
Sir, firstly, that the chunks of pathology may spread from one to other as we are having a common chamber. And secondly, sir, one is advantage is there, sir, because we are having a more wider anastomosis compared to Baker's. So that may be we do for end-to-end anastomosis, sir, actually for these patients.
Yes, but if there is a recurrence, then both the systems.
Both the systems will be involved.
Survival of the patient will
Yes,
be
sir.
happening.
That is a known disadvantage, sir.
In that case, I think Beaker will be better.
Okay, thank you, Dr. Bidipta and Dr. Gautam Mandal, for a nice presentation.